Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. Feel free to ask questions in the chat box as we go along, and your questions will be more than addressed. So today we're continuing our infectious diseases month of September 2024. We are continuing on from learning about the basics of bacteriology, microbiology, and clinical microbiology from last week. And this week we're actually going to be learning a little bit more about parasites and fungi. So the fancy terms for them is mycology, which is a study of fungi, and parasitology, which is a study of parasites. So we're gonna first, introduce the both concepts, like what is mycology, what is parasitology, what is the difference, and then we'll also incorporate some clinical case studies throughout, so we can sort of apply all that we're learning. So again, this is just, I would say, a drop in the ocean of what we learn in medical school in terms of all of the different diseases, symptoms, manifestations, the things that we see on microscope in terms of diagnosing specific diseases. They're all very clinically relevant, but today I'm just sort of highlighting a handful of them so that you can get a better idea of how we sort of learn about them in med school. There are a lot of different visual mnemonics that you can also apply when you're memorizing them. There are some really good resources like Sketchy. Sketchy is basically a visual mnemonic picture storytelling tool to sort of remember all these different bacteria, viruses, parasites, and fungi. So with that said, I'm going to start off and kick us off with mycology. So mycology, like I said before, is the study of fungi like mushrooms and yeast. And this is an image right here showing the structure of fungi. And I want you to also notice how fungi, they're similar to human cells. I talked about this last week where, they're also eukaryotes. They can be both, but they are eukaryotes. They have a nucleus and other key cellular structures like, oops. They also have other key cellular structures, basically like microtubules and a cell membrane. So here I basically, like in orange, I underlined for you what the similarity is with human cells. But there are some key differences that I didn't highlight, like the cell wall here. Just this one example. Remember, cell wall, they're not in human cells, but they are in plant cells. So if you're thinking of a mushroom, I remember this, okay, well, it's like a plant, right? Mushrooms are like plants. They would probably have a cell wall. So fungi also have a unique molecule in their cell membrane called ergosterol on the left. It has a similar structure to cholesterol in human cell membranes and also has a similar function. It basically, cholesterol in the cell membrane, if you'll remember from like cell bio classes, it basically provides structure and support to the cell membrane. So ergosterol does the same thing for fungal cell membranes. We'll talk about this a little bit more later on in its applications to pharmacology. Because ergosterol is different from cholesterol, we're able to target ergosterol if there is an infection from a fungi, and if there's ergosterol, then we can actually make drugs, and there are drugs that target ergosterol. So that would be beneficial because it's not targeting human cells, it only target what's not supposed to be there. So that is a huge concept that I wish I had drilled in my mind before med school. Like if it's not something that's native to us, then it's something that is fair game for pharmaceuticals. So, like I said before, like antifungals, like ergosterol is an important target of those certain like antifungals. There's one example, it's called nystatin and amphotericin B. And that's like one target of them, like ergosterol, very important to remember. And I'm emphasizing it for a reason. So another difference between human cells and fungal cells is that they have a cell wall that's composed of chitin. And so, just in summary, like fungi, they are similar to human cells. They have nucleus, cellular structures like microtubules, and a cell membrane, but they also have like these key differences that are not underlined in red, basically. Like one key difference is the ergosterol in their cell membrane, similar to cholesterol in our cells and human cells. And this molecule, ergosterol, is targeted by antifungals, like nystatin or amphotericin B. Another difference is the cell wall, which has chitin. There's also beta glucans. There's also mannoproteins, and these are also drug targets as well. But I just want us to focus on one drug target, which is ergosterol, just for today's purposes. Now I'm going to talk about the two main different types of fungi. There's filamentous and yeast. So filamentous fungi, they have hyphae that collective, like basically a bunch of hyphae together, they form a mycelium. So that's just one thing to remember. And then a bunch of mycelium make up something called a mold. So that's just I just wanted everyone to understand that. So here in this, you can see here there's a mold on the left, and then yeast looks a little different on the right. So um, so a bunch of hyphae make up collectively a mycelium. And on the other hand, yeast, which is the second major type of fungi, yeast are single-celled and they reproduce by budding. So if you'll remember maybe in high school biology or I remember learned this also in ecology in undergrad, where budding is a way for prokaryotic or monocellular organisms to reproduce asexually. So there's that. It's a good little reminder of why I learned that so long ago. And there is relevance for this because some fungi they're monomorphic, aka they just exist in one form, either a yeast or a mold, while there are other types of fungi that are dimorphic fungi, and they can exist in both forms depending on environmental conditions. So usually mold tends to be in cold temperatures or like it exists in colder temperatures, and yeast is in heat or exists more so in heat. And so that follows a mnemonic, mold in the cold, yeast in the heat. So that's just one way I remember mold and cold rhyme. So usually in colder environmental conditions, if there's a dimorphic fungi, it would likely be in its mold form. There are also fungal spores. Spores are very important for reproduction, also survival in very harsh environmental conditions. And while both the fungi and bacteria, they produce spores, fungal spores are different because they're actually less durable and they're structurally more distinct. Like we actually sometimes in some questions, we have to be able to look at a specific type of spore that is given to us like an image from a microscope and be able to identify sometimes just based on that what disease, like what type of fungi is causing this manifestation, this specific clinical picture. So just understanding like the spores for fungi, they're much more distinct. They're much more interesting. And I'll give you some examples in the next slides. So most fungi, they do produce spores, unlike bacteria. And bacteria, very few species produce spores. And a classical example is a diaper rash caused by Candida albicans, which is treated by targeting ergosterol in the fungal cell membrane. So again, here's that relevance of ergosterol. I'm mentioning it again. And so antifungal drugs like niacin, they target structures that are unique to fungi, like ergosterol. I know I'm repeating myself, but understanding the differences in fungal cell structures and types helps you identify effectively, like diagnose and also treat fungal infections. So now I'm going to talk about fungal infections specifically. Fungal infections are also known as mycoses, so I'll refer to them as mycoses from here on out. So remember, mycology is a study of fungi, and then mycoses is considered a fungal infection. Now, there are multiple different types of mycoses. You can see here on this graphic by osmosis.org, which is another really good resource that med students use to understand some things in colorful, like animated form. The types of mycosis, I just want you to focus on this here. So there's a superficial mycosis, a cutaneous mycosis, subcutaneous, also systemic. But for our purposes, I'm just going to focus on superficial mycoses versus systemic mycoses. So superficial and systemic mycoses, they're both types of fungal infections, also known as mycoses, that can affect the body in different ways. So as you can see here, a superficial mycosis, you can also sort of guess that these infections, they affect whatever is superficial to you, like your skin, hair, nails, and they're also the most common type of fungal infection. So they're also known as cutaneous mycoses because they're superficial. So they include tinea infections like ringworm and yeast infections, like uh, pidia, I'm really bad at pronouncing these. Uh, Pityriasis versicolor. That's just one example of a superficial mycoses. And then systemic mycoses, these are infections that spread systemically throughout the body, and they affect internal organs like the lungs, the brain, the gastrointestinal or GI tract. They're generally caused by opportunistic fungi, and they're much more serious than other types of mycoses. And I'll define what is an opportunistic fungi in a later slide. So just remember that at the back of your head. So again, look, subcutaneous or superficial or systemic mycoses, you can sort of tell from their name where they're affecting the body, right? So if it's something that is systemic, it's much more deep. It's actually affecting multiple different organ systems, right? Whereas a superficial mycoses would sort of stop at just your skin barrier, you could say. So, like a subcutaneous mycosis would just mean that there is a mycosis that's affecting tissues under the skin, but it wouldn't be systemic unless it does become systemic, if it goes a little bit deeper to the other tissues and spreading throughout the body. So the signs and symptoms of mycosis, they really vary depending on the type of infection and where it's located. So, for example, a superficial infection can often cause like a rash, while deeper infections could cause like pneumonia-like symptoms or meningitis. So mycoses that spread throughout the body are called systemic mycoses, and usually they manifest in pneumonia. So I hope that sort of makes sense, sort of differentiating between the two. Again, this is just for you to have a sort of exposure before med school, like a pathway to medical education, like a boot camp of medical education. And again, we're just going over, like I guess you could say, like a droplet of it, and going a little bit slower than it was taught to me in lecture. So in the context of systemic mycoses, there's something called endemic. And endemic refers to a disease that's like regularly found in specific geographic regions. So there are certain fungal infections like histoplasma, coccidioides, and blastomyces. They are endemic to specific areas of the United States. And you have to know that really well, because sometimes question stems will ask, like, oh, so this patient who is from the Ohio River Valley comes in with XYZ symptoms. So when you hear that word Ohio River Valley, there's a reason why that piece of information was put in there. Sometimes it's not relevant, but it often is. There's a reason why a specific geographic region would be mentioned in a question stem. And in this case, you can see on this map here, like if I know if I know what disease is usually endemic to the Ohio River Valley, it'll yield me more points on test day. So for example, like histoplasma is found in the Ohio and Mississippi River valleys, and histoplasma is indicated in green on this map here. And coccidioides is found in the southwestern United States, in this like muddy orangey rust color. And blastomyces is the one in blue here. These are usually found in areas around like the Great Lakes and also the Ohio River. And these fungi are more common in these regions due to like environmental conditions that favor their growth. So I would often wonder, like, why is it, that it's not, doesn't necessarily mean that someone who lives in Florida wouldn't have like a blastomyces because it's not colored in the map. No, that doesn't necessarily mean that. But for example, if you are going to medical school or seeing patients where I do in the state of Maryland, in Baltimore specifically, they do see much more blastomyces in the emergency department. So just good to know, just a general I guess you could say a general roadmap. So, coccidioides, that is endemic in southwestern US. Actually, I can go on the next slide and explain a little bit better. So I'll start off with histoplasma. So histoplasma capsulatum, and I put the map on the top right corner here just so that we can revisit it and don't have to keep going back and forth. But basically, the histoplasma capsulatum is this dimorphic fungi. So remember, dimorphic, what does that mean? That basically means that this fungi will basically change whether it is a mold or a yeast, depending on its environmental conditions, usually temperature. So if it's cold, it's mold. And if it's in the heat, it's usually a yeast. So that's what makes this a dimorphic fungus, a dimorphic fungus. So it's histoplasma is dimorphic to Ohio and the Mississippi River valleys, like I mentioned before. The infection is actually transmitted by inhaling spores. So it's present in soil that's contaminated by like bird droppings and also in like bat infested caves. So sometimes like I'll read a question about like a patient who like adventured in a bunch of caves and just like was like hit by a bunch of like bats coming out of the cave. So that's like usually indicative of like histoplasma because I know that that's sort of found in the soil that's contaminated in like bat infested caves. Most infections of histoplasma tend to be asymptomatic, but it can present with fever, pneumonia-like symptoms, skin ulcers, and also granulomas. Granulomas, I don't know if we've gone over this before, but I think in one of our prior like immune system lectures or probably like for our fundamentals of pathology series we had earlier in the year, we learned about a granuloma, which is basically like I guess you could say a bunch of neutrophils that gather together, blocking off. Actually, let me just make sure I'm defining granuloma correctly, which is also good for my review. Um, Basically, granuloma is like a tiny cluster of like a bunch of white blood cells, which include neutrophils and other tissue. They're not cancerous, but they are basically form as a reaction or aggregation of a bunch of macrophages that form in response to a chronic infection. So good thing I looked that up. So there are granulomas in histoplasmas, and also sometimes patients present with hepatosplenomegaly. Now, from this word hepatosplenomegaly. So it is from this word, even if you never heard this word before, hepato tends to refer to like hepatocytes. So that's referring to the liver. And spleen. So hepatosplenomegaly basically just means an enlarged spleen, an enlarged liver. Um, and also lymphadenopathy. A lymphadenopathy is basically your lymph nodes basically swelling up. So for a laboratory diagnosis for histoplasma, you would need to get a sputum smear stained by a specific type of like biopsy, like it's called like a Giemsa or a bone marrow and tissue biopsy, and that basically would show you what you see in the picture here in the top left, this intracellular budding yeast inside of macrophages. You'll also be able to see like cream colonies at a specific temperature, specifically 37 degrees Celsius, which is hot. And you'd be able to see the budding yeast forms there. And then a past or present infection will also give like a positive delayed hypersensitivity test. And again, this is all hitting on our like immunology principles. And there's also other laboratory techniques like ELISA, CFT, and also an immunodiffusion test for antibodies and also DNA probes that detect fungal nucleic acids that can also be done to be able to tell for sure that it's histo. And when you know that it's histo, you want to be able to treat it. Now I'll move on to blastomyces dermatitis. And this is another dimorphic fungus that's endemic in the Great Lakes area, Ohio, and also Mississippi. The infection actually occurs by inhalation of spores, and it presents clinically as pneumonia-like symptoms, fever, chest pain. Again, these are very vague symptoms, right? You want to be able to do some lab testing and also find out the patient's history. Like, where are they from, right? Did they travel anywhere? That's how infectious disease doctors they tend to have very, very detailed histories because you kind of need that to help guide you to the correct clinical diagnosis. So again, I was talking about how the symptoms include like the fever, chest pain, pneumonia-like symptoms. There can also be abscess formations in disseminated forms. There can also be osteomyelitis, and this can actually cause skin nodules, ulcers, and also fistulas that can happen due to trauma. So the only way that you can correctly like and confidently differentiate from differentiate the blastomyces from the histo is by microscopy. Like you have to just be able to see it under a microscope because you would actually see a more thicker walled yeast from like basically has to have like broad-based budding, and that's That's like a buzzword, broad-based budding, and that's how you're able to tell and differentiate when there is a question and you want to be able to differentiate blastomyces, blastomycosis from a histo. There will also be like colonies at 37 degrees Celsius that have creamy yeast-like characteristics while at room temperature. They'll show like septi hyphae and something else called piriform conidia. Now, again, I know I'm just saying a bunch of vocab words, not defining all of them. But again, it's just so that you have an idea of like, you need to know, you actually do need to know like 80 to 90% of this, because if you don't know like one fun fact about this one in mycosis, like it might be the one fun fact that's mentioned in a question stem that might lead you to be able to understand a specific type, like that might lead you away from a specific treatment. And yeah, so that's very important to know that. So, yeah, like similar to histo, the yeast forms will be seen on tissue biopsy as well. And then there's also nucleic acid detection through DNA probes, which is why it's very important to know your biochemistry um, techniques, like to understand how to diagnose things. There's also immunodiffusion and ELISA to also detect antibodies to the blastomycosis. And then the third one that I haven't mispronouncing before, but it is actually pronounced coccidioidomycosis. Okay. That is endemic to the southwestern United States, in California, in southern Nevada, in Arizona, etc. Um, it's also called the desert valley fever. And infection is usually caused by the inhalation of arthrospores. And clinically, it'll present to you as a fever, a chronic cough that mimics tuberculosis, myalgia, arthralgias, and also erythema nodosum. And it can also disseminate in immunocompromised individuals most of the time, causing meningitis, osteomyelitis, also lymphadenopathy, etc. And to diagnose it, you'd usually be able to do it through a tissue biopsy, which would show like thick-walled spherules with endospores. And it's also a dimorphic fungus, so it would change based on its temperature. So if it's being cultured at room temperature, it would show hyphae and also some rectangular or barrel-shaped arthrospores. And then you'd be able to detect the antibodies through ELISA, CFT, other precipitation tests, and then a delayed hypersensitivity skin test to the fungal antigen. Um, Specifically the fungal antigen involved with the desert valley fever, that would become positive during the infection, but it would also remain positive a few more years even after clinical cure. So it's very interesting that those antibodies would still stay in the body. And if you take an immunology in college or you understand a little bit of immunology, you'll understand why, but I'm not going to get into that today. We might get into that maybe another month. Now let's talk about the desert valley fever, but with a clinical case scenario. So I'm going to read this case study. So a 45-year-old male farmer from Arizona presents with a 2-week history of persistent cough, chest pain, and also fever. He reports frequent exposure to dusty environments while working in the fields, and a chest X-ray reveals multiple lung nodules. And based on the patient's location and occupational exposure, a sputum culture was obtained, confirming the presence of Coccidioides immitis, which is a soil-dwelling fungus endemic to the southwestern United States. And so we were able to diagnose it. Of course, I also hinted at it, that this is desert valley fever, which is a fungal respiratory infection. So this patient is then went on to be prescribed fluconazole or itraconazole, specifically to prevent the dissemination of the infection to the other parts of the body, such as the bones, skin, and also the central nervous system, which is which is much more at risk in people who are immunocompromised or those with severe disease. And this is clinically relevant because this case highlights like the importance of like knowing the regional endemic fungi, right? In patients who present with these specific respiratory symptoms, specifically in those who are exposed to like dust and soil, right? So this is a farmer. So again, this is sort of hinting to you that this farmer, usually farmers, they are outdoors, they're working, toiling the soil, or they're involved managing it. So that's sort of what they were hinting at here. And And remember, coccidiomycosis can range from a mild respiratory illness to a severe disseminated disease depending on the patient's immune status. So remember, these are all systemic mycoses that I'm going over with you right now. I think I forgot to mention that before. Like all of these are systemic mycoses. Yeah, it's in the title. All right, so now I'll talk to you all about opportunistic fungal infections. Opportunistic fungal infections, they basically occur when fungi, which are normally like harmless, they take advantage basically of weakened immune systems to cause illness. And these infections typically affect immunocompromised individuals, such as those who have HIV or AIDS, cancer, and also diabetes. One example of an opportunistic fungal infection is something I've already mentioned earlier in the lecture called Candida albicans, which is a dimorphic fungus that can also form pseudohyphae and yeast cells. And it commonly causes oral thrush, esophageal thrush, vulvovaginitis, and also diaper rash. And then in more severe cases, it can actually lead to disseminated candidiasis in immunocompromised patients. And the treatment would actually include antifungal medications like fluconazole or nystatin, like I mentioned before. And remember, nystatin, how does that work? The pharmacology behind it. It would affect the ergosterol, which is basically the human cholesterol, but for fungi, in the fungal cell membrane. If that's targeted, then that means that the cell membrane of the fungus would be like would disintegrate, and that would actually prevent the fungi from doing its job or being infectious. We talked about this similarly for antimicrobials last week. That's basically what they do as well, because you want to be able to target things that are not human cells, but you're working with the human body because they've infected the human body. Um, Now, Candida albicans, you can sort of remember this. Well, alba means white. They're also dimorphic. They form pseudohyphae and they bud yeast at 20 degrees Celsius. So you can see in A, this is what happens at 20 degrees Celsius. And then they also form germ tubes at 37 degrees Celsius in B. So you can see that this is a dimorphic fungus because there is mold in the cold and then yeast in the heat. So this can be either a systemic or a superficial fungal infection. It would cause oral and esophageal thrush. So oral thrush you can see on the right hand side. It would cause that oral thrush in immunocompromised people like babies or neonates. Also people who are taking steroids that tends to suppress the immune system. People who have diabetes and also AIDS. Also, vulvovaginitis would also be caused through the diabetes and the use of antibiotics, diaper rash in little babies, and also infective endocarditis, people who basically mainly in people who inject illicit substances. So again, there are many different ways someone can manifest with this disease, and so you just have to be able to take a detailed history. You would treat this through oral fluconazole, like I mentioned before. A lot of fluconazole, in fact, even like there are fluconazole like shampoos to address like dandruff because that's caused by fungus as well. So you could also use like amphotericin B for like the esophageal or systemic disease. And there are many other examples of opportunistic fungal infections as well, like Aspergillus, Cryptococcus. There's also Rhizopus, but for purposes of time, I just wanted to focus on one example of an opportunistic fungal infection. So here is another case study, and it's the same question that you'll see on the certification quiz, so make sure you're paying attention. So a 2-year-old boy has a diaper rash due to the fungal organism known as Candida albicans. Targeting which of the following structures would be helpful in treating this patient's condition? Is it A, mitochondria, B, ergosterol, C, cholesterol, or D, protein synthesis? I'll give you a second to think about that. Okay, so the correct answer is B. I hope that you got that from the many times I was mentioning it earlier in the lecture, and this is why. So in fungal infections like Candida albicans, the cell membrane contains this unique molecule that's unique to fungi called ergosterol. And that's absent in human cells. What do human cells have instead in their cell membranes? They have cholesterol to support their cell membranes. So antifungal treatments tend to target this structure. So for example, nystatin and also amphotericin B, they would bind to ergosterol, that then creates pores in the fungal cell membrane, and that leads to cell death. The other options like mitochondria, cholesterol, and also protein synthesis, they are common to both the fungal and human cells, so targeting them would likely harm the human cells as well. So therefore, like targeting ergosterol is the most effective treatment here. And again, I put the picture of the fungi here so you can kind of remember ergosterol is unique to the fungal cells. Now that we've talked in depth, or a little bit in depth, about mycology, now we're going to talk a little bit about parasitology. So you might remember, I remember learning this in middle school and again in high school, like something called symbiosis. Symbiosis is basically a long-term interaction between dissimilar species that live together in basically like a biological association. So like there are beneficial relationships that we have with many different of basically of the microbiome of our gut because there are bacteria that actually help us digest a lot of different things and make us happy. So we have a lot of bacteria on our cells that are good, right, for both us and also the bacteria to grow. That is a mutual like that's an example of mutualism. But basically like depending on the degree of dependence and the advantages or disadvantages of the host and also the person who is not hosting and just sitting there, symbiosis can be classified in three different ways. So there's parasitism, communalism, and mutualism. So mutualism is what I talked about before, where a relationship exists between the symbiont and its host, and it benefits both parties. So um, I'll just like talk about this in order. So like parasitism is basically like the relationship between a symbiont, or like in this case it'd be the parasite, and its host, um, in which the parasite actually benefits from the relationship and the host is harmed in as a result. So it could even cause death to the host. So an example would be like tapeworms, head lice, things like that. Like that is like a parasite. So I'm going to talk about all parasites coming up. But commensalism is basically a relationship between the commensal and its host, where the commensal benefits from the relationship and the host has no benefit or harm. So basically it's one-sided, but the host is not being harmed. Some organisms can be commensal under like specific conditions, like some skin microbiota in a healthy individual. We can live without our skin microbiota because like if you wash your face, you get them off, but it doesn't affect you unless you have like an allergic reaction to the chemicals in the face wash. But usually you're fine if you're a healthy individual. But these can actually become pathogenic if conditions change, like if you have like a host immune deficiency or there's a colonization of different sites. Like there's something called Staph aureus we talked about last week, which is normally found in the nose, but if it's found in other areas of the body it basically if it goes inside or like comes in systemically or subcutaneously, Staph aureus can cause disease as well. But normally it is found in our nose, but not like but that's superficial. There's some like an example of like a commensal, I would say is like E. coli, which is normally part of the physiological intestinal flora, but it can cause infections when it colonizes, like if it colonizes the urinary tract, it can cause a urinary tract infection or a UTI. And then mutualism is basically a relationship between the symbiont and its host that benefits both parties, right? So similar to the commensals, the mutualism can become pathogenic under certain conditions, so I talked about the microbiome that helps. There are like bacteria produce vitamin K, which are very important, which is a very important mineral. We talked about this before during biochemistry month last month. Vitamin K is very important for you. And bacteria produce that, but we allow the bacteria to colonize in our gut because we have favorable conditions for them. And so if we're allowing the bacteria to colonize, they're using some of our resources, but they're producing vitamin K as well. So we're benefiting. So I hope that sort of explains to you like the three different like relationships, but we're specifically going to focus on parasites where the host would not benefit. The host would actually be harmed. So Parasitology specifically is the study of parasites or organisms that live on or inside a host organism, specifically us, because we're talking about human or clinical parasitology, and they would benefit at the host's expense. So parasites are categorized into three main groups you can see here. There's protozoa, helminths, and also ectoparasites. Um, so helminths include the nematodes, cestodes, and also trematodes. And protozoa also has like different places you could find protozoa, like if it's in the GI tract, CNS, or blood, and another. But I'm just going to focus on for today, one GI tract protozoa, one CNS or central nervous system protozoa, and I think one ectoparasite, which is lice, of the Pediculus humanus. So the rest of them we're not going to touch on, but I just wanted to show you all this flow chart. This is all just the parasites that we tend to learn for the USMLE Step 1 exam. So again, there's a lot, right? So I just wanted to show you all the various like interesting like human parasites that we can find, including helminths are also known as worms, the protozoa, the eggs, and these parasites can cause a whole wide range of infections from intestinal worms like Ascaris lumbricoides and the Tania species to protozoa like Giardia lamblia and also Entamoeba histolica. So understanding the morphology also helps you in diagnosing and treating these parasitic diseases, especially if you're in a resource-limited setting, where these infections are more prevalent, like in more developing countries, you could say. And I don't know if you'll remember from Dr. Green's infectious disease sessions. In fact, the certificates are open again from his like 3 or 4 sessions. He's talked a lot about how his life as an infectious disease doctor, he tends to do a lot of like global mission trips, and he actually travels like to Africa, to South America, and helps treat these many different types of infectious diseases. And of course, like as an infectious disease doctor, you're literally the specialist for treating fungi, treating parasites, treating all the different bacterial infections, and also combating antimicrobial resistance. But with that said, I'm going to now switch gears and talk specifically about those three parasites that I chose to highlight for you all today. But remember, there is a whole plethora of them. So this one specifically, Giardia lamblia, it causes a gastrointestinal infection, GI infection. Um, and this is a protozoa. So remember we talked about there are protozoa, then there's helminths, and then there's ectoparasites. So there's those three main types of protozoa. So Giardia lamblia causes giardiasis, which leads to foul smelling and fatty diarrhea. It's commonly contracted through fecal oil transmission by like drinking contaminated water, usually while hiking or camping. So sometimes you'll see like cases talking about a patient who recently like hiked or camped. And you can only know that by getting that history from the patient. You want to ask them they had any recent travel or things like that if you're suspecting this disease. But basically this is a trophozoite parasite. It's often described as a pear-shaped flagellated protozoa. And you can see here on this purple thing right here, that is a pear-shaped flagellated protozoa. And the treatment usually involves metronidazole. And there are a lot of visual mnemonics. I was watching one earlier from physio, which like showed me like a metro train bus to remind me that the treatment for Giardia lamblia would be metronidazole because it has the word metro in it. Now I want to just quickly talk about another case study like related to this, and this is another certification quiz question that we'll have for you all when you're taking your certification quiz. So you're welcome for giving you the answers. So a 23-year-old female presents to the clinic with abdominal pain for 2 weeks. She explains that her symptoms began shortly after returning from a short camping trip near a lake. She denies intentionally drinking any of the lake water, but admits she accidentally swallowed a bit one time while swimming. The physician orders an ova and parasite or ONP examination of the stool. And usually when you're doing like a stool examination, that's the main way to be able to diagnose this disease. So It's called an ONP exam of the stool. And the lab techs, they're basically looking at the ova and the parasites, and the eggs. But the lab basically confirms the presence of several pear-shaped flagellated trophozoids. So based on the likely pathogen, which of the following is the patient most likely to experience at some point during her infection? So this is like a two-step question, right? First, you have to be able to identify like what like disease this is, and then remember all the different like fun facts associated with it, right? So there's bloating, there's flatulence, there's foul-smelling, non-bloody fatty diarrhea, often seen in people who have camped or hiked, and cysts in the water. So that's how it's transmitted. But basically, like if I know that this is Giardia lamblia, then I also need to remember that is there a short period of vomiting? No, there's not much vomiting associated. There is abdominal pain, so I'd cross out A. Is there blood in the stool? Well, I don't. It says non-bloody fatty diarrhea, so I would cross this out as well in my head. There's no mention of painful headaches. I think that's associated with a different type of disease. So I would pick C, repeated bouts of loose stools. And basically, repeated bouts of loose stools is really just referring to diarrhea. That's just another way of saying diarrhea, right? So the presence of the pear-shaped flagellated trophozoites in the stool points to Giardia lamblia, which is a parasite that causes giardiasis. And this infection is commonly associated with contaminated water resource, like water sources, especially from like lakes or rivers, making her camping trip a likely source. And the Giardia infection typically causes the prolonged foul-smelling, fatty diarrhea. Like diarrhea, this like already smells bad, but this is like more foul-smelling diarrhea. Along with like abdominal pain and also bloating. And repeated loose stools are a hallmark symptom of this condition, like diarrhea, which aligns with the patient's history of accidentally swallowing lake water. So again, it's just one like a good application of the clinical like parasite we just learned about. Now we're going to learn about a CNS or central nervous system infection protozoa, right? This is still a protozoa, Naegleria fowleri. And this is known as the brain-eating amoeba. And I just wanted to talk about this one because people talk about like brain-eating parasites all the time, I feel. And so I was like, oh, I was very surprised that it's actually a real thing. This is a parasite that causes a rare but very fatal infection from swimming in warm, fresh water, which leads to meningitis. And or like basically like meningoencephalitis, I would say, and that's typically very fatal. Like the treatment is very challenging for this disease, but it can help sometimes with amphotericin B. There are very few survivors though, and I would say amphotericin B like rarely prevents death, just based on what I've read so far. And then basically how this goes into the brain, which is also very interesting, like how it's transmitted. Basically like you're swimming, let's say. When you're swimming, the water goes through your nose, but how does it enter your brain? So this is a really good application of anatomy here. So if you'll remember, let's think about the olfactory nerve. The olfactory nerve, also known as the nerve that is related to smelling, the sense of smell. So if water does go through like intranasally, then it can actually enter through the cribriform plate. And I wish I had a picture of that. Let me actually find one. Cribriform plate be very helpful for this. So here, yeah, here we go. So there's basically an opening, you could say, like, and I only remember this because this is why we do like anatomy lab in medical school, where we tend to have like cadavers, people who have donated their bodies to science in order to be able to see these things. And also you can see it in like any skeleton. Basically, this is a view of if I cut this part of my head here and then I open it up like this is basically the inside of my skull, the top part of my skull. And there's something called a cribriform plate, which is basically where the olfactory nerve comes out of. And that's basically how, like, because there's that little hole there, it can actually go through the nose and into there. So that's sort of how that happens and affects the brain, because remember that nerve is connected to the brain. Um, so that's basically how it gets through the brain. And basically, like symptoms wise, you might see like a mention of neck stiffness and also vomiting. And again, it's usually fatal, and you would find amoebas in the CSF. CSF stands for cerebrospinal fluid. And cerebrospinal fluid is basically a fluid that you can find basically like it's this clear colorless fluid, and it's a clear fluid that's basically found in the brain and spinal cord. And you can actually like do a lumbar puncture to like lumbar puncture is basically a procedure we've talked about before in a previous teleshadowing session, or you can also Google it. I can just Google it now for you all. Lumbar puncture. And basically here you can actually get cerebrospinal fluid. And from there you can actually find amoebas. And if you find amoebas, you can actually suspect Naegleria fowleri, especially if the patient is presenting with neck stiffness and also vomiting. So I hope that made sense. It's very interesting to me when I was reading about it, and I was like, oh, they really are like, it is literally like a brain-eating amoeba. All right, now we're going to talk about an ectoparasite. So far we've talked about protozoa, those two types, basically the Giardia lamblia and also the Naegleria fowleri. Now we're going to talk about an ectoparasite. Now remember from this chart all the way back here, we've talked about a GI tract protozoa, a CNS protozoa, and now we're going to talk about all the way on the right side here, an ectoparasite, and specifically lice, because I remember lice is something I'm pretty familiar with, or actually, hearing about that growing up in elementary school and stuff like that. Of course, we may already know this already, but lice are basically these small blood-sucking parasites that live on the human scalp, body, or also the pubic area. And we have hair in all those three regions. The most common types are head lice, also known as the Pediculus humanus capitis, and they cause itching and irritation and also pruritus. Lice are basically transmitted through close contact or sharing personal items like cats or combs, and they're very common in school-aged children. I'm remembering this Arthur episode right now when there was lice. And clinically, lice cause intense itching and also discomfort. The treatment typically involves like topical insecticides like permethrin or pyrethrin shampoos and thorough cleaning of the bedding and the clothing to prevent reinfestation. And I just want to show you all, these are the three different parasites basically. So this is the Pediculus capitis, which is the head lice. It looks a bit different from the Pediculus pubis. It's also known as like a crab lice. It looks like a crab basically. And this is found in the pubic or perianal regions. And this is the Pediculus corporis, the body louse. And now louse is just singular form of lice. Lice is the plural form. And this is on this red area here, it's called a nit. A nit is basically like the little egg that the lice sort of like put on your your little hair follicle. That means they stick there. It's hard for them to come off. Um, Another interesting thing I learned about this is back in the day, like I'd say like 10, 15, 20 years ago, they would recommend school-age children stay at home during, when they have lice and to come back after they're done infected with lice. But actually, the recommendations have changed now for lice. If actually, like according to the CDC, like children with head lice can actually go home at the end of the day, get treated, and then they can return to class after they start their treatment. They still have like lice going on. The CDC like has said that the head lice, they're not considered to be like a communicable disease because lice don't carry disease. It's basically like the nits that have, so, it's basically those eggs essentially. So as long as, the children aren't like sharing cats and stuff and combs, children with lice, students with lice, they don't need to be sent home early. And that way they don't need to be away from school for a really long time. That would really affect their education, right? Because there used to be something called like a no-nit policy, and students with lice no longer need to be sent home early, basically. Like it's very interesting. And this will actually prevent the burden of missing a lot of school days. So, just an interesting fun fact. Like you don't need to, children with head lice can be treated at home without interrupting school attendance. That's what it says. So yeah. And then I think the one thing I didn't go over is like how these body lice, so specifically the Pediculus corporis, the body lice. And you can see here, it's actually like a lice that just had just sucked someone's blood. But basically, these ones can actually transmit rickettsia, like an epidemic typhus, and also have caused like relapsing fever and also trench fever. So that's just one fun fact to know about this specific one. That's why it's important to know all three because only one of them is causing this type of transmission of disease. So yeah, fun fact about lice. Now we're gonna go over a question, just so we can, remember it. I just feel like having questions helps me remember things much clearer. So, a 13-year-old boy presents with persistent scalp itching and white particles attached to his hair shaft. So, white particles, what you're thinking of, these are the nits. On examination, excoriations on the scalp are also noted. And an excoriation is basic. Okay, I have to show you. An excoriation, yeah. This is what you would see on a scalp lice. Yeah, so this is what you would see caused by lice sometimes. And they're also noted, so which of the following is true regarding lice infestations? A, head lice are primarily transmitted through contaminated water. B, body lice can transmit diseases such as epidemic typhus and relapsing fever. C, pediculus humanus is a type of lice that infests only the pubic region. Or D, children with head lice must be excluded from school until all nits are removed. So we just talked about D, that is not true. We also talked about how the pediculus humanus, I don't think that is a lice that infects only the pubic region, because it also infests the perianal region. Head lice, they are not transmitted through contaminated water. They're usually transmitted through like the nits passing on through like sharing of hats, combs, stuff like that. So the only correct one would be B, that body lice can transmit diseases such as epidemic typhus and also relapsing fever. So remember that lice, they are ectoparasites that cause intense pruritus. So let's just define pruritus. Lice. Pruritus is basically itching, right? And also it can cause excoriation, which we've seen already, on the scalp, neck, axilla, which basically means armpit, or the pubic areas. And the different species of lice can transmit diseases. So specifically the body lice, or the pediculus humanus corporis, no, it's a mouthful, it's Latin. They are known to transmit the epidemic typhus and relapsing fever, and also trench fever. And the treatment typically includes the use of topical insecticides, right? And also nit combing. And children with head lice can also often return to school after the first treatment without the need to remove all the nits beforehand. And that will help prevent kids from missing so much school. And again, this is just a revision, like just for me to sort of get to the point where how, we didn't go over all of the parasites and all of nematode, we didn't really have time to go over, nematodes, cestodes, and trematodes, but the same thing applies basically, very similar, it's all like basically a bunch of fun facts, not fun facts, obviously, it's important for having, the best patient care possible. Understanding all these diseases will help us narrow our differential diagnoses for the more common infectious diseases, specifically in parasitology and also mycology. So with all that said, I hope that this was informative for you all. I'm going to be wrapping up the teleshadowing session now, and you can receive certification for attending today at teleshadowing.com/certification. Next week we'll be going over viruses, and remember that all of our previous teleshadowing sessions, I think over like 150 or so, have all been reopened for students who want to take courses, and we really want to learn in depth like about a specific specialty. So we actually have that all available to you all now. I'll show you exactly where to find it on our TeleShadowing website here. So you just have to go to courses, and then you can basically, this is our landing page of all the specific specialties. So if you want to learn about psychiatry, learn about it. There are a bunch of interesting things about it there. And then there's like a playlist as well of all of our different, we've had, I think, over 11 psychiatry sessions. And then you can just take the quizzes after you watch all the sessions in case you've missed them in the past. So I hope that was all helpful to you. I know that is something that a lot of our students really wanted. So we listened to your feedback, and they're all available for you now to take. And thank you so much for attending today's session. I hope to see you at the next week's session as well on viruses, and that will basically conclude our infectious diseases month.